One of the common topics that you will come across and common parameters that we measure in post-operative cardiac surgical care is arterial blood gas monitoring, which we call as ABG, starting for arterial blood gas. Now, you should take some time and have a look at the ABG parameters because it gives a list of lot of parameters in the printout that comes out of the ABG machine. Out of them, there are only 4 or 5 that we are really interested because the rest of them are all calculated based on these 4 or 5 parameters. The first and foremost are the oxygenation parameters, that is PO2 and the PCO2, and followed by the acid-base component of it, that is the bicarbonate levels and the base excess. And then we also get information on hemoglobin level and electrolyte levels, and then in some ABGs also the lactate level. Now we'll take each topic and then see how monitoring the ABGs will help, and what are the common conditions that can cause problems and how to rectify them. So the first and foremost is the oxygenation component and the PO2. Now we should realize what is the difference between PO2 monitoring and saturation monitoring, saturations. By saturation we mean that the percentage of hemoglobin that has got oxygen in it. So a patient can have 100% saturations, but his PO2 levels can be low if his hemoglobin is low or for other conditions. So it does not equate that saturations is equal to PO2. They are two different parameters. Now, what does PO2 stand for? It's the partial pressure of oxygen in blood, and the normal levels are around 90 to 120 kilopascals. Now, this can be measured in millimeters of mercury or in kilopascals. Some units do it in kPa and some units in millimeters of mercury, and the normal oxygen levels should be more than 90 to 120 millimeters of mercury, and 9 to 11 kilopascals. So now, what are the conditions where the PO2 can reduce? Whenever there is any problem with oxygen exchange in the lungs, like pulmonary edema, or it could be mechanical problems like tube getting blocked or the patient getting awake and is not being ventilated properly. In all those situations, the oxygen levels in the blood can fall down. It is very important to identify what is causing the problem. Is it the problem with the ventilator? Is it the problem with the tube, that is the tube connecting from the ventilator into the patient up to the lungs? Or is it the problem with the lungs? Or sometimes there could be problem beyond the lungs with the blood itself. So very important to know that what is causing the low PO2 levels and then try and address it. Then only the patient is going to get benefited. Never have a knee-jerk response of low oxygen means okay, increase the FiO2 and that will take care of oxygenation. No. Always try and identify what is actually causing the problem. Yes, as a temporary measure you can increase the amount of oxygen you are giving to the patient, but eventually that will not help unless you address the actual problem. Say for instance, some patient is having low blood pressure and low perfusion, and hence his PO2 levels are low. In such situations, just increasing the oxygen will not improve the oxygenation levels, because what is happening is, because of sluggish circulation, because of low cardiac output, all the oxygen is being extracted from the blood, and so again when the blood is coming back into the lungs, the amount of oxygen that can be added will be limited because of pulmonary edema or something, and so the oxygen levels are coming down. In such situations, the only way to get the oxygen levels better is by improving the cardiac output. So either by increasing the inotropes or whatever is the pathophysiology that is causing the low cardiac output situation, we need to address that, and that only will help improving the PO2. Sometimes and most commonly it is important to check the post-operative X-ray to make sure that the endotracheal tube is not gone too far into the right lung or is getting kinked somewhere, which could be detrimental, and that can cause immediate decrease in the oxygen and can lead to cardiac arrest. So in those situations, again, it is a easily correctable thing. And when patients are waking up, sometimes when they are anxious, they tend to bite on the endotracheal tube. In such situations, again, the oxygen levels can come down, saturations can get reduced. Again, there it is important to identify what is causing the problem and address it. My colleague Dr. Lakshman will deal more with the ventilatory parameters. I am only giving you an overview as to what could happen. Now, there is an important relation between oxygen saturations and PO2 levels, which is called as an oxygen hemoglobin dissociation curve. I'm sure you heard about it in your physiology classes. Basically, it is a sigmoid curve. It starts and ascends up fast and then plateaus off slowly. What the curve tells us is that if say we come the reverse way, if the oxygen saturations are falling down, then at a particular point the oxygen saturations fall will be less, but the PO2 fall will be much steeper. So for anyone who has got a saturations of 98 to 99%, if their saturations come up to 95%, that is still acceptable. But if the saturations have started coming down below 95 to 92 or 90, then their oxygen levels decrease dramatically when compared to the number itself, as we see in the saturations. So just for example, for argument's sake, what we can say is, if the PO2 levels are 120 when the patient is saturations are 100, the PO2 levels will come down to around 105 or 102 when the saturations come up to 98. And when the saturations come down up to 95%, then the PO2 levels will come up to 90. Whereas from 95 to 92, the PO2 levels will fall from 90 to 70. And if the saturations become less than 90, between 85 and 90, the PO2 levels can come down as low as to 60. So you can see, as the saturations are falling, initially the fall is only very little, but once it touches something like 95 to 92%, then the fall in the oxygen levels in the blood is quite steep. So never allow a patient to have saturations less than 92%, and if possible less than 95%, unless they are used to such a situation preoperatively, or there is a special situation where we have accepted that these are acceptable saturations. If nothing like that is there, never accept saturations less than 95%, because what that means is the actual blood oxygen content, that is the PO2, is far less than the number 95% that you see on the screen. And in such situations, you can, if the patient is not on oxygen, you can start on oxygen. If the patient is already on nasal prongs, you can start them on face mask, because face mask gives more higher concentration of oxygen. If the patient is already on face mask, then you can put them on CPAP or BiPAP, which give pressurized oxygen, and things like that. Or if you are not sure about any of these, inform your senior saying that this person's saturations were 98 and 99 earlier, now they are 95%, I am not happy with this, please look at this patient. Then further action can be taken. Now the second parameter we look at is the partial pressure of carbon dioxide, PCO2. Now if you take the PCO2 in kilopascals, it is 4 to 6, whereas in millimeters of mercury, roughly you can say it is about 40 to 60 millimeters of, or anything above 40, you should consider it as CO2 retention. Again, carbon dioxide retention happens in situations where there is a block to the ET tube, so it can happen at the ventilator level, at the tube level, at the lungs level, and at the blood level. So again, we can go into details of it later, but more importantly, it is important to identify why the carbon dioxide levels are increasing and then address it. And the best way to address carbon dioxide levels is by increasing the respiratory rate on the ventilator. Once you increase the respiratory rate, you are increasing the carbon dioxide expulsion, and so the consequences of having high CO2, which is called as respiratory acidosis, is compensated by increasing the ventilatory rate. But some ventilatory parameters will not allow any increase of respiratory rate. So the best way to see is by increasing the rate by 2 breaths per minute or maximum by 4 breaths per minute at a time to correct and make sure that the PCO2 is coming down. Now, PCO2 forms, or carbon dioxide forms, an important integral part of acid-base mechanism in the body. So let us now talk about acid-base mechanism. Now, in our blood, we have to realize that there are both cations and anions, and there is something called as an anion gap. That means if you just measure the electrolytes, then the cations which have got the plus sign on them, like the calcium and sodium, if you add the total of them, then add all the negative ions, that is the chloride and bicarbonate, then you will find that there is a gap, that is the anions, that is the negative ions are slightly higher in number than the cations, but this cannot happen. So the reason for that is because there are some cations that are like in the form of proteins and all, which we are unable to measure and on routine arterial blood gas, and this parameter is called anion gap, or in our common language it is called base excess. So actually, starting.